Just a word about our evidence-based medicine this week. We're going to be looking at a clinical practice guideline, 300, I don't know, hundreds and hundreds of pages of these guidelines. They usually have a packet guide for you, usually have a tutorial that makes it a little less overbearing. When you first glance at it, you just are overwhelmed. I always am. But actually, as you go through the structure, it's very practice friendly, okay? So when we utilize clinical practice guidelines, there's a few things to keep in mind. This is going to be very high in your evidence pyramid. You are generally going to see a weighting example, which I'll show you the next slide. There's always a statement on how they made their guidelines and who comprised in the panel. So sometimes, again, these are guidelines. These are to help guide us. This isn't a substitution for individualized care, and I always stress this. So the difference in the structure of the guideline panel can influence the perspectives, okay? So panels may be comprised of specialists, primary care clinicians, or both. They often include other healthcare experts like epidemiologists, public health specialists, or statisticians. So the composition really may influence the perspectives and through which the evidence is interpreted or weighted, okay? So keep that in mind. Also, there are differences in the weight assigned to the evidence. So scientific evidence helps to describe the continuum of benefit versus harm. But guidelines are essentially they're a value judgment on where to set your thresholds for recommendations, okay? They're not a substitution for individualized care and decisions. Also keep in mind the panel's biases, okay? So areas of uncertainty may be interpreted differently by different organizations. For example, clinicians see patients in the numerator, so they're oncologists, they're seeing cancer patients, so their clinical practice is constantly diagnosing cancer patients, right? Where in family practice we hopefully have very few of those. But their exposure is so predominantly to the benefits of treatment and screening, they may be more biased towards more aggressive guidelines. So if you are seeing these broader range of patients in the denominator, okay, like a primary care physician, like I said, or PA, excuse me, you're going to see the smaller ratio of diagnosed cancer, okay, compared with overall screening, and then maybe you see that potential harms are associated with screening without the benefit, okay? And then epidemiologists who may view rates and ratios may be biased more towards conservative guidelines and monetary savings.